I'm certainly excited to be here today to share with you some of the work that has been going on with CRISM and that I've had the opportunity to participate in the national guidelines. So I thought how we'd proceed is that I'll go over a little bit about the background, the purpose, and how we unfolded, so the process, as well as some of the findings. And then we're going to follow the presentation with a panel discussion, so an opportunity for you guys to ask questions and certainly be involved. So, certainly to put a few things into perspective, it's always important to kind of look at the background. And when we look at CRISM, it has been certainly a project and an initiative that has been supported and undertaken by our CIHR. So that's the Canadian Institute for Health Research, which is an independent agency. Its mandate is to certainly be an investment in the research for Health Canada, and it is accountable to the Minister of Health. Now, through one of its branches, the Institute of the Neuroscience and Mental Health and Addictions, came the CRISM, and CRISM is our Canadian Research Initiative for Substance Misuse. And this was initially determined to be a 5-year initiative, certainly modeled after the U.S. National Institute on Drug Abuses and Clinical Trial Network, with really the goal of taking that evidence-based practices and research and translating that into clinical forefront, the healthcare system, and certainly being a tool for all of us as providers to use. In September 2015, 4 nodes were operationalized, and you can see those there highlighted with the red stars. 2 being the British Columbia and Ontario as standalone nodes as provinces, and then certainly our Quebec and Maritimes, as well as the prairies with the help of the Northwest Territories. So as many of you know, I don't have to convince you that we have an issue with opioids here in Canada, and certainly even on an international level. But just to provide you with a couple statistics that help inform about that. In 2016, our Public Health Agency of Canada declared that there were over 2,500 deaths in Canada related to opioid overdoses. Certainly in BC, where they had seen a large impact from this, their rates of fatality had increased from over 87% between just 2015 and 2016 alone. And in Alberta, from 2013 to 2016, it had pretty much went from 66 to 363 deaths. So whether you want to term this a crisis, an epidemic, this is a real problem that we're all facing. And certainly something that when Health Canada wanted to develop national guidelines to help providers deal with this situation, CRISM was very well suited and well positioned to take on this task, given its large multi-network, certainly a lot of providers, a lot of expertise placed throughout Canada to bring that national lens. So when given this tasks, certainly we want to look what would be the purpose of this national guideline? And, based on current scientific information, we wanted to ensure that we were providing evidence and information that could be used as educational tools for healthcare providers on the front line. Certainly also something that could be a document that could help inform our government, where they could support policies and move things forward, so that way that could help change the healthcare system at large. And certainly help to bring some standards of care across Canada from that national lens. One consideration is that as we moved forward with these guidelines, we certainly realized that we couldn't encompass completely everything, meaning that we decided to take a focus on the oral opiate agonist treatments, because that is what our current state is today here in Canada. And so the primary focus of these guidelines focus on that. However, there is recognition from our committee that there are the injectables, the implantables, and other methods of treatment that are on the forefront and that research is building. And this document is also meant to be something that would be revised on an annual basis to reflect current practice. So kind of like that working document. There's also considerations for the special populations. So that might include those who are pregnant, our First Nations populations, elderly, the youth, in our incarcerated populations. And so for those, again, for that added expertise, those are things that we would support as we move forward, that extra research and time be spent to help provide that best practice lens with that special lens on those areas. So even to rewind, when we talk about opiate use disorder, there's still a lot of stigma and many misconceptions. And, as we had a discussion earlier this morning at our table, people still believe this is simply a choice. And one of our purposes in this document was to help provide kind of that definition and understanding of what opiate use disorder is as that chronic relapsing medical condition that someone would struggle with for a lifetime, like any other chronic disease. And that's not something that's simply a choice. And there's a lot of research in terms of starting to look at that, the brain changes that occur in terms of our dopamine uptake, the neural pathways for reward, judgment, decision making. And so we're aware of this and certainly support that as part of this document. We also realize that there's very much that potential to have this condition in remission and have the supports for persons struggling with opiate use disorder to function functionally within their life. So how did we proceed? Well, as was alluded to earlier, certainly BC had made some movement prior to the CRISM establishing these guidelines. And so certainly recognition going to the Vancouver Coastal Health Providence Healthcare Guideline, as well as the BC Centre on Substance Use, as a lot of the information was started and initiated by them. But from that, we proceeded with a very rigorous literature search. And certainly the areas that we focused on were the medically assisted withdrawal management. So what does detox, in other words, its role within the treatment, residential programs, as well as long-term, obviously, opiate agonist treatment, including primarily Suboxone and Methadone. And I'll talk a little bit about that in a moment, as well as the psychosocial supports and treatments that are available. And all throughout, again, we cannot emphasize the importance of harm reduction and how that fits on that continuum of care for those with opiate use disorder. So when we looked at the literature, we used the GRADE tool. So that's the grading of recommendations, assessment, development, and evaluation. And essentially what that does is it looks at the research available and categorizes them firstly based on the type of study. So, was this a meta-analysis, randomized control, certainly being at the highest weight, moving down to individual observational studies, and then, clinical experts being more at the lower ranked based on that grading tool. From there, it was then reviewed and assessed based on other things like potential bias, certainly if it was able to be reproducible, consistency of the results. And so that happened in the second evaluation assessment stage. And then there was a final kind of weight provided or decision that certainly looked at the lens of the quality of the evidence and then that strength of that evidence. And so that's something that we base the final recommendations on, which I'll allude or preview you to very shortly. So once the literature had been done, there were 4 nominated principal investigators within each of the nodes. And what they had done is nominated 4 clinical leads within those respective nodes. And what they were tasked with was to form the consultative team. So that would be the committee that represents expertise within each of the nodes, and probably about 7 to 13 experts within each province. And so once that was established, they were now going to take this reviewed literature and look at the evidence and how this translates into practice and provide that expertise lens. And so in our final amounts, that ended up with 44 experts from across Canada who participated in the review process. And this is the internal part. We also had an external review, which included peers, and included the Canadian Association for People Who Use Drugs, Mums United and Mandated to Saving the Lives of Drug Users, and certainly a couple international experts as well. So trying to provide kind of that complete view within this. Now, of those 44 experts, just for added information, that included people who worked within the field, from primary care providers, addiction specialists, psychiatrists, social workers, nurses, nurse practitioners. So it really encompassed the whole practice, managers and administrators as well. So the consultation process essentially began in February 2017, and that included a first period of 3 weeks where all of the committee members had that opportunity to review the working document, provide feedback, and then that was brought back to the table. The revisions were made, and then there was a second internal review, which included another 2-week period where they had the opportunity to then go back and review again. And then it came back to the committee, who proceeded to move that from the external review, which went out for, as I said, on the international, and to the external reviewers, who then brought back for the final review from the full committee. So lots of opportunities to make those changes that are appropriate, and certainly to make the amendments that would most best represent Canada. So just a little bit about some of the content. When you have the opportunity to look at the national guidelines as soon as they are released, we devoted 3 particular sections, the first being a bit of the information on background, methodology, and kind of a bit of a summary of our recommendations. The second portion has a lot of the extensive literature, both on methadone and Suboxone, the opiate agonist treatment, as well as some of the withdrawal management, residential programming, psychosocial, along with certain considerations. And then interestingly, what we've also provided in this document is appendices that has reflections of each of the provinces in terms of training, education standards, what their recommendations are expected, in the summary of kind of what their practices are. And so that's helpful, again, when we look on changing policies, bringing kind of those national standards, and kind of getting a glimpse, where are we, where can we improve, and where can we meet, and kind of get ideas from things happening elsewhere. So for certainly that context of our opiate agonist treatment, a lot of time was gone through in discussion about both methadone and Suboxone. So methadone being our full opioid agonist in a liquid formulation. Just want to spend a bit of time talking about some of the advantages and disadvantages that we highlighted in this document. Certainly when persons are started on methadone, it can be an easier initiation in that they don't have to be in withdrawal. So that could be considered certainly an advantage with methadone. There was also the literature showing that there was better retention, particularly those suffering from this severe opiate use disorder. And it may be more effective in managing the withdrawal symptoms as well in that category. There's no maximum dose because it's a full opioid agonist. Certainly it's also approved for pain control. So those were some of the key highlights for the advantages of methadone. In terms of the disadvantages, obviously this is something that can be diverted, and so from the public harm perspective, that is a concern. To have methadone across Canada, there does require the Health Canada exemption, which is or has been another initiative that CRISM is looking at to evaluate. But as it stands, that is certainly the case. There's a more severe side effect profile. So in terms of things like lowered cognition, erectile dysfunction, increased risk for respiratory depression, those are things that we would be concerned with methadone certainly as well. And again, with some of the drug-drug interactions like the QTC prolongation, perhaps with other medications that the individual may be taking, as well as their own innate or individual cardiac concerns. So something that certainly you want to be aware about. And the less flexible or flexibility in terms of take-home doses. And so that's something that impacts the program and the life of the individual. And if you were going to transition from methadone to Suboxone, it can be a little bit more of a challenge. So those are some of the highlights in regards to advantages and disadvantages with methadone. If we were to look at Suboxone comes currently in that sublingual tablet, and that's that partial agonist, and it's got the buprenorphine and the naloxone built in. So for Suboxone in all of the provinces, there is no Health Canada exemption required, so that could be an advantage, one barrier less in terms of prescribing. There's certainly a decreased risk in terms of overdose potential, as I alluded to, with that partial agonist, and so kind of that ceiling effect, and also that less risk for respiratory depression. Again, for diversion, not as easily diverted as methadone in the general public, although we are aware in the incarcerated populations that's not always the case. A milder side effect profile, so not as at risk to have, the sweating, the erectile dysfunction, although sometimes some of the side effects can occur. There's a shorter time to achieve therapeutic dosing, which is a very important advantage. Within 1 to 3 days, someone potentially can become stable on Suboxone, and so that's certainly another important advantage. And less drug-drug interactions comparatively to methadone. Again, we understand many of the patients are on multiple medications, and so that's an important lens. And for take-home doses, there's certainly a lot more evidence that there's that flexibility, and this can be very important in recognizing areas within Canada that are rural and remote. So there's that potential to help in those cases. Some of the disadvantages might be that this, when initiating, certainly someone can go into precipitated withdrawal if they already have opiates on board. Certainly if they were to inject, the naloxone would kick in and become active and put them into withdrawal as well. And I guess some of the education on how to dose and how to take that sublingual tablet can be a bit of a learning curve for the patient themselves. But most of these are not unsurmountable barriers. So here's a little glimpse of some of the covered approaches beyond just the opiate agonist treatment. And I want to highlight at this time some of the research in terms of the quality and strength, what was found in terms of these recommendations related to these areas of withdrawal management, the agonist treatment. So in terms of that high quality and strong recommendations, certainly when someone's going to initiate opiate agonist treatment, Suboxone being where the most feasible, certainly the number one choice. But where it is not possible, methadone would be certainly the second choice when Suboxone is not the preferred option. And if someone were faring poorly on Suboxone, methadone would then be the subsequent choice. So a lot of high quality and strong evidence for those particular angles. in terms where the research showed more the moderate but strong recommendations, if someone were successful on methadone but did want kind of that easier transition or easier practice because they don't want to go dose daily, that certainly consideration for a taper and switch to Suboxone be considered. If both Suboxone and methadone are not able to be the choices of opioid agonist treatment, that slow-release oral morphine be considered. And in that instance, it's very much recommended that that be someone who holds the methadone exemption or has the expertise of working with the slow-release oral morphine. When we talk about the withdrawal management, that detox or withdrawal management alone certainly be avoided. We know that there has been a lot of increased concern with certainly relapse, more increased mortality and morbidity associated with that pathway. So withdrawal management alone not be or avoided and not be recommended. And if in the case that you are to proceed with the withdrawal management, that certainly a slow taper, preferably on an opiate agonist treatment, be considered. And that would be more than a month, so not like a week-long taper. And if someone is on methadone or Suboxone, has been successful over a period of time, that again, a very slow tapered approach be the way to proceed in these cases. And that could be, again, over a period of months to years. And in terms of psychosocial treatment, interventions and supports should be routinely offered in conjunction with their opiate agonist treatment, but not that it's mandated that you will only get your methadone Suboxone if you have the psychosocial treatment. So we recognize the importance of that, but it's not a has to one or the other. Ideally, you will have them all, but that it can't be held as a bargaining tool. In terms of lower and weak evidence, when someone has been, let's say, off their opiate agonist treatment or they're now in that abstinence phase, there is consideration for the oral naltrexone as an adjunct to help provide some of that achievement in terms of cravings. And then again, when it comes to that moderate and strong category, again, a lot with that harm reduction and offering the important general healthcare services to these individuals, because often that can be lost. And so that's a strong importance that we see all throughout whichever care you are providing, kind of like on that continuum. So I love images. And often in medicine, we have algorithms and pathways. And so we decided to include a pathway here for those who like that visual. So if you see, and I'm not sure if you can see the colorings, but certainly within the green for go, if once a diagnosis of opiate use disorder has been made, recommendations would be go for opiate agonist treatment. Obviously, if possible, the psychosocial treatments available, some of the residential programming, any of the other supports that might be available in conjunction, but again, not mandatory for the treatment. And the first choice being Suboxone. If there are any contraindications or it's not possible in your area, then consideration for the methadone, which we see down in the yellow. And if methadone is contraindicated, then moving as the third line with the slow-release oral morphine. Then to the right of our pathway, we certainly see that going down to the red, avoid withdrawal management alone or detox alone. This is unsafe. And again, the education around that is very, very key, because when we talk about some of those misperceptions, and many people might hold that idea that, detox is treatment. And so providing a lot of education, no matter where they are on these, about safety, certainly also with the harm reduction, which I'll come to in that last box there. But, and if they are to choose this way, again, providing that education, trying to show them the evidence for having at minimum, the slow taper with the opiate agonist treatment for their own safety. And then potentially moving, as you see that dotted line, going back up to opiate agonist treatment, having them hopefully being able to at some point move, if possible, into opiate agonist treatment. And then the box on the bottom, again, harm reduction, providing access and information on, clean needles, supervised injection sites, not sharing take-home naloxone kits, which many of the provinces do have. But these are all very important along that continuum. So in essence, this is kind of the summary of what our guidelines will be showing to a more extensive degree. And so where does that leave us? Well, certainly we're having that opportunity to provide it to our node today. We did share these at the CCSA this week and at that conference, and we're preparing for the release of these hopefully in the end of November, beginning of December. But from there, we want to look at how can we now disseminate the national guidelines and make those useful for you in each of your provinces, whether it means helping to advocate on the government level in terms of the policies or helping with education with the providers who are going to be using these guidelines. So kind of that whole knowledge translation piece is very important. And then certainly looking at what are the next steps in terms of additions to the guidelines as we move forward, keeping them up to date, and some of those considerations that I talked about earlier about special populations, and also being open to the new modes of treatment as they become available. What I would like to do is invite my colleagues Ron and Peter to come forward, and we'll have a kind of open panel discussion for you guys to ask questions, provide comments, feedback, certainly on some of the things that we've discussed this morning, or certainly things that as it moves forward, what concerns you, or what are your burning questions. So thank you.
My question is about how long it would be recommended for them to stay on the agonist therapy, and particularly for adolescents who may have been started on this more recently, what's the data or what's the recommendation on how long they should be on it for?
So there's no specific recommendations in a particular specific amount of time. We know that this is a chronic illness that is going to have the phases of relapsing, remission. We want to be supportive and adaptable to that continuum and support them where they're at. Now, certainly when we look anecdotally, we have patients that come onto the program as they taper off, then they're back in. And so we recognize that this is something that we need to adapt. There's no particular recommendation that it has to be at least 1 year or specifically 6 months, but that we certainly continue to follow the individual and ensure that we're matching to their needs. And I don't know if you have any other.
Yeah, I think from a clinical perspective, there is, as Ginette had said, there's no fixed time. Well, we do know that relapse rates are very high if you take them off too soon. So in a clinical scenario, the way to do it is to make sure, number one, that they're totally stable in all aspects of their spheres, emotional coping, social determinants of health, etc., is extremely stable. And then we can then try to taper, but go slow, very, very slowly, so that we can reverse the doses at the first signs of instability. But there is really no fix and fast rule. That's the main thing.
And that slowly, again, is months to years. And most often patients, they'll recognize, we need to hold now. I'm not ready going down. So again, that individual.
Generally speaking too, and it's no surprise, I would correlate to the severity of the opioid use disorder. So somebody with a more severe opioid use disorder is more likely to take a longer period of time to stabilize and address some of the core issues, whether it's trauma, concurrent mental illness, and some of the basic socioeconomic determinants of health that we've commented on. So that can take 1 to 2 years. With regards to youth more specifically, and what's coming into the forefront of the discourse around this is the concept of recovery capital. So how heavily impacted have they been on one hand, and what resources do they have to help them transition into recovery on the other? The shorter duration of time of use has a better prognosis. So you would think that a youth would have a better prognosis if you're able to get them stabilized, get the supports in place, and help them to transition on. You can't be entirely sure, though, so you have to work with them. It's a process. It's not an event. It's not time limited. But the hope is that with the right support, youth wouldn't need to be on as long-term maintenance therapy as you would see with somebody who's coming in with 10 years on the streets, for instance.
I just had a two-part question. I'm just curious about what you see for difference in diversion of Suboxone versus methadone, and then also if there's any different considerations around carries of Suboxone, or what the policies around carries.
So certainly when we look at the evidence, Suboxone, comparatively to methadone, is not in the general public diverted. It's not as preferred in that regard. When we think about both, it's important to remember that these are substances that don't, and medications that don't provide that kind of high like some of the other opiates. So, given on a market with options, this would not be the preferred go-to. It's very much to prevent going into withdrawals, right? And so, first of all, when we have kind of that understanding, we know that it's not, the desired option in that way. Methadone, because it's formulations, it's liquid, it is that full opiate agonist, it does have more potential for diversion and problems in terms of overdose. And some of the literature shows, and again, if you look in the US, that methadone is in the results in terms of autopsies of persons who have overdosed. Now, what we do see with the Suboxone is that because of its profile, again, with the sublingual tablet, also the fact with the naloxone built into it, and that partial agonist, all of those properties make it less desirable in terms of diversion. However, in certain populations, for example, in incarcerated domains, it may be diverted in terms of being cheeked and then passed on, and again as a kind of more last resort. So that's kind of some of the context in terms of those. And I think, again, no matter what treatment, we always want to be educating our patients about risks associated, the safety, about how we keep our medication. If we're going to have take-home doses, certainly we provide lockbox with key that are checked for our patients in terms of those. But those are some of the reasons, and I guess some of the profiles as to the Suboxone comparatively to the methadone.
Yeah, I think both medications or both molecules right now we see are being diverted, particularly more so in the correction system. We see more for the buprenorphine diversion because methadone is not as common there. The issue is safety in the sense that with methadone, it's a lot more dangerous when it is diverted and used with other full agonist opioids. Buprenorphine is safer. It's not to say that in certain populations it's completely safe, particularly for those who are concurrently using benzodiazepines and other sedative hypnotics. You can inject the buprenorphine naloxone and still get a euphoric effect, because the naloxone part only lasts for 45 minutes to an hour. The buprenorphine lasts a little bit longer. So when people co-inject it with benzodiazepines or some other sedative hypnotics, it ties them over that period of time, and then you can still get the effects. So it is just less abusable. And all the data that we have right now suggests the methadone is 6 times more dangerous than buprenorphine, naloxone. There is a street value right now to both. And in the correction system, I think 1-2 milligram pill goes as much as $20 to $30 per pill, partly because people are diverting it to prevent their withdrawal symptoms, not so much to attain an euphoric effect. So the other question you have is about the flexible dosing. Is that right? So right now, the purpose of the Optima trial is to look at a non-inferiority for buprenorphine naloxone in a flexible take-home dosing compared to daily dosing for methadone. Most of the studies that we have right now comparing the two molecules is with daily dosing in a controlled environment. Because of the safety profile of buprenorphine naloxone, this national trial that we are doing is to look at whether the flexible dosing, meaning getting carries straight away once they are on a stable dose and they don't have all the concurrent risk factors, is just as effective and non-inferior to methadone. So stay tuned on that.
One of the issues with regards to carries, of course, is what the provincial regulations are, the standards and guidelines that are determined by each province. And what's interesting, and you'll see it in the appendix, is the variation across the country. And even with methadone, which is more highly regulated, there's variations in terms of how quickly people can earn take-home privileges or carries. Excuse me. Similarly, with buprenorphine naloxone, although it has a much better safety profile, there's still quite a range with regards to the jurisdictions and whether or not people can have take-home privileges relatively rapidly, or whether or not it requires a period of good urine drug screens under monitoring before they begin to earn those take-home privileges. So what that tells us is that we're still trying to figure this out in terms of what is best practice. And the opening up of buprenorphine and naloxone broadly, particularly in primary care, poses some challenges because sometimes the prescribers may have very little, if any, knowledge of addiction medicine, which is a concern. And yet, on the other hand, it increases access. So again, this is in process.
Hi. Yeah, I think it's me. Very laudable work, thank you. One question, which is the horrible statistics you presented at the beginning. What proportion of the national ones and the provincial ones do we know were due to opioid use disorder, as opposed to occasional use, say, of fentanyl? And has anybody looked at, for example, in Alberta, the chief toxicologist data would have the 363, and cross that by health service use data to see the proportion of OUD out of the cases? Related to that question, if there's a possibility that a number of the deaths may be occasional uses because only one tablet is sufficient to kill you of contaminated fentanyl, what are we doing to guard our youth against that, please?
So I always like to say when it comes to data and numbers, certainly we're only at the tip of the iceberg in terms of all the kind of picture and context around that, and for multiple reasons. One, it's hard to collect. Even the numbers that we do, it's based on autopsies. Not everyone goes through those, right? That's not always captured. Is it possible to gather the information if they specifically had an opiate use disorder, or was this a one-time recreational use? One thing that I can say is we're starting to recognize the value and the importance of collecting this data, and I think this document is something that can help inform provinces to the importance of continuing to look at aspects, certainly of things like you have just mentioned, and then what can we do about that? So I can speak certainly that in our provinces, or in my province, we recognize that youth certainly are at risk. There's a lot of education campaigns that are going out about using, if you're in, a scenario and opioids are available to, or substances are available to, use a small amount, use in conjunction with someone, so someone can, call for help, be armed with something like a take-home naloxone kit, make sure that all of these pieces are there to do things in the safest possible manner. And certainly, I think that strong prevention education part is very important for youth, alike with anyone. And so I think that's something that's very, very important with that. Now, like I said, with the data, I think those are things that as we move forward, we need to do a better job of collecting. And that's another hope that this can help provide some ammunition, to say the least, for some of that value.
Sure, may I just make one follow-up comment, which is that it may not be respiratory depression that kills you, though. It could be cardiac, it could be muscle rhabdomyolysis, etc., which a naloxone kit isn't going to do anything for. So one suggestion is that the Health Canada lab that does test substances routinely tests everything that's on the streets and essentially works out what contaminants, what nasty things are in there, and that's attached to a public health campaign. I mean, obviously we should be putting out the message that no drug is safe.
Yes.
And we should be underlining that with data to support that. Just a suggestion.
Yeah, thanks for that question, because this is the crux of the problem right now, is the potency of the contamination or the contaminated drugs on the street. Looking at, history, adolescents or youth, goes out and sneak a couple of cigarettes, puffs, or alcohol drinks. That's not fatal. Nowadays, with the potency that's resulting in the deaths. Now, your question about trying to determine how many are actually use disordered or how many are just experimenters, I don't think we have that type of data, but what we do have in Alberta is the most recent release of the statistics have showed that how many individuals who have passed away from an overdose have contacted a service within the last 30 days. And what we have seen is that up to 30% of the people who have passed away within the last 30 days have contacted, a prescription and obtained a prescription of opioids or something from a pharmacy. We do know that about 10% have contacted an emergency department or an acute care hospital. And so you can extrapolate that in those individuals are the ones who may have a much more severe use disorder than the experimenters. But to actually have a firm diagnosis of where they were at before they passed away, I think we don't have that data at this time.
I'd like to add a comment with regards to the toxicology, and there's another layer of complexity here, and I agree that it would be wonderful if we could have that level of testing. But I think it's important to keep in mind, particularly with the synthetic opioids that are available, that have been produced typically offshore, frequently in China, come from molecules that have been described in the literature, never really produced before, but are now being produced and being sold on shore here. Can't even be tested for. We don't have the methodology and the toxicology standards. Now, they could do it forensically, but they're generally not part of a routine panel, and it would require specialized testing methodology in order to determine, was there a synthetic opioid involved in this death? And if so, what is it? So this has immense implications from a public health point of view, because if we can't detect it, it's hard to start tracking it in terms of what's the market distribution and so on. So there's other layers to this that are really quite concerning.
Thank you for the presentation. I too love flowcharts. They kind of make sense. And I'm hoping that you will update the flowchart and include information on supervised injectables, because yesterday there was an announcement from the Federal Minister of Health that this will be more readily made available. And I know it's available in BC in a limited form. We're looking forward to moving that direction in Alberta. So it'd be nice to see that on your flowchart, how that would reflect That is one question. The second is, are there any plans to develop guidelines like this, for example, for users and families? Like from my own experience, when our son was on methadone, he said, well, how much longer I have to be on this? Are you tapering yet? And, for families to understand what it actually means to be on it stable. Like our son, thinking back on it now, he was never stable on it because he would not dose very carefully on his carries, and then he would supplement from the street. And how I see it now, it should be like snakes or ladders, when you supplement, you are actually not stable. It extends that period. And often people go off because of family pressure. And it would be really, really important to have these kind of guidelines available in a way that users can understand, but also families can understand what the purpose of it is, how it should work, and what the alternatives are, and on all that. I mean, So, and just one small point: there is an initiative between between Health Canada and the Medical Examiner's Office in Alberta to review files again and look for additional data, such as if the person, like any information the family might have provided, such as if the person was a long-term user or if this is a first-time use. They are looking at getting additional data, but they can only get at that if it's in the health file, of course.
So coming to your first comment, that was a big discussion we had about, do we include injectables, implantables, knowing that this is certainly the direction where newer modalities are moving forward. But then what we decided that was to, again, because of time frame, the urgency, the importance, the value, we wanted to certainly produce what was available here in practice across Canada to help establish these first steps, knowing that down the line that adapting to all of the other modalities as that moves forward would certainly be something to consider. And I actually really do like your idea about, yes, this will be available to everyone, but to have kind of knowledge translation pieces that are focused to family, because you're absolutely right. Stigma lies everywhere in healthcare providers, with families, with friends, and those are often barriers that patients do realistically have. And so that's an important thing that we will certainly keep on. How can we target the information for family members, loved ones, and I think that's a very important comment.
Yeah, I don't have much more to add about that, except that maybe I totally agree with you about the fact that, with these guidelines, we want to translate it to the general population, not just to first-line healthcare providers, because clinically we do see the backlash to what you're describing, where family members are putting a lot of pressure on the patients to come off sooner than what they should be.
And a third comment is really around the discourse that we have with regards to these different initiatives that come forward. Simply because it's medicalized doesn't mean it should be conflated with treatment. And I think that some of these initiatives, such as injectable heroin, should perhaps be more appropriately framed as medicalized harm reduction as opposed to treatment, so that we have a better way of looking at the narrative around what it is that we're doing here in that continuum of care. What in the basket of services in the continuum of care are more appropriately framed as harm reduction, with the potential to transition to treatment? What within treatment, and with regards to opioid use disorder, we're looking primarily at opioid agonist therapy. Some of that is going to be facing more towards the harm reduction end of the spectrum. Some of it is going to be facing more towards the recovery end of the spectrum. And what are we doing to enable and support people in the transition, for instance, from treatment into recovery? And of course, the movement back and forth. So if we're looking at different modalities, then we also need to be thinking about where are they appropriately positioned in the continuum of care? And what is the evidence that supports their being framed, for instance, as harm reduction as opposed to treatment, as opposed to something that's more recovery supported? So that's another way of looking at this through the lens of the continuum of care as well. The microphone's behind you.
Yeah. 2 more
On the question of the use of the word recovery, a point I like to make is that we need to redefine recovery. Too often recovery is equated with being abstinent or being drug-free, but recovery is really defined by the person, the person who's on long-term opioid agonist treatment is in recovery. People in the Salome study are in recovery. Somebody who's on a stable dose of Percocet or oxycodone is in recovery. So recovery is defined by the person, and if we equate recovery with being drug-free, we are setting people up for failure, and in many cases that means death. So we don't want to do that, and I think if you would talk to some user groups, they would disagree with you if a supervised injection, if that is treatment or harm reduction. There are certainly people who might disagree with you on that. So 2 points, thank you.
And I don't disagree with the principle of the importance of the broader definition of recovery, and indeed that's included in the definition of recovery that comes from a number of different organizations that include supportive therapy as part of recovery. There's no debate about that. The question is, are we enabling people or helping people to achieve their highest level of function, or are we chemically ghettoizing them so that they don't pose a problem to the population? If you deconstruct some of these things, we may be writing people off prematurely, and that's my concern. I would strongly advocate for the resources and support for people to achieve their highest level of function that's possible, not to shut that door at any time. But I'm not limiting that definition either.
I have 2 questions. One about the, I know in each and every province there are diverse models of care. Some of them, they practice very limited restrictions, and others very high restricted structure to methadone treatment. And so my first question is that based on the evidence that you found in relation to the type of models that are being used across the country, what kind of model are you advocating for, and for what reason? Secondly, we also do acknowledge that there are many barriers that clients of methadone they are confronted with. So, do you have a sense of how perhaps the clients can be supported so that they become successful in care, as opposed to just being there only for them to fail? Because when you consider the high attrition rate of clients on methadone treatment, there has to be a way in which a mechanism has to be found, perhaps, that encourages them to remain in treatment. So, have you perhaps devised a way in which clients can be encouraged to remain in the program?
Yeah, I think when you're talking about models of care, what the evidence that we're showing today is that for opioid use disorder, the first line treatment is the use of buprenorphine naloxone, because in response to the current evidence, it is the best to prevent relapses, dangers, risk, death, overdoses, etc. So depending on which jurisdiction you are in, the access to the use of buprenorphine naloxone remains limited. And in the US, we have these office-based opioid programs where community physicians utilize buprenorphine naloxone as part of family medicine. And that is the idea that I personally would like to see it in the hands of, where there are opioid use disorder individuals in primary care. It's hidden in chronic pain. It's hidden in patients with concurrent disorders. So it's somewhere that it should be in that realm, and it should not be in specialized clinics. Having said that, there are complex patients that have many other polysubstance users, concurrent mental health issues, severe physical disabilities that should be managed in specialized settings. So this is how I see where the treatment should be encouraged across the board.
There's one last question. I think we can move to the last question.
Hi there.
I was just wondering how, if any way, these guidelines might change for patients with concurrent opioid use disorder and chronic pain disorder, because that's a particularly challenging population, I found.
Yes. So that's a really tough question. There are guidelines out for the chronic pain management that have certainly stirred up some commotion and discussion. And we have these working for the opiate use disorder. And we know that people who have opiate use disorder also have other concurrent mental health. And again, for the general treatment, this is certainly where the evidence shows. I think that all those other special considerations, we kind of want to tie back where there's that kind of continuum of care and other models where if we look at opioid use disorder like a chronic illness, like your diabetes, right, the basics would be able to be managed in that kind of primary care based on this kind of model of information and these kind of guidelines. But the additional complexities would then require the assistance of specialties, which might include psychiatrists, specialists in addictions, who could help provide in those other layers. And I think those are certainly things that we see as a value to look at further research as we move forward from this base.
Great question. The issue is that buprenorphine naloxone is not indicated for the treatment of chronic pain presently. Methadone is. The molecule itself is effective for patients with chronic pain. The complexities of it is that there are many patients within the chronic pain realm who actually have opioid use disorder or addiction to it, if you want to use that word, that will benefit from buprenorphine naloxone on its own in that population. So the chronic pain and opioid use disorder or addiction patients is kind of complex. It's a spectrum by itself. There are patients who use chronic pain as an excuse to misuse and obtain opioids. There are those with actually pure chronic pain with no aberrant behaviors that primarily is over-reliant because of concurrent mental health issues. And so the guidelines gives you the what to do, the how to at the front lines level, where you're going to have to distinguish which category the actual patient in front of you is what the knowledge translation that has to be done. There is still more work to be done within the chronic pain realm, but definitely great question.
I think one of the challenges is the number of people who have a primary chronic pain disorder with a concurrent opioid use disorder that end up being treated primarily in an opioid agonist therapy clinic setting, which isn't properly set up for the treatment of their chronic pain. And that is problematic in itself, but it gets compounded by the fact that there's often not good access to non-pharmacological approaches for the treatment of chronic pain. And indeed, that's probably one of the reasons why they got into problem to begin with, is because medically and otherwise, we rely too much on pharmacology and not enough on some of the non-pharmacological therapies. We don't provide access, for instance, to exercise therapy, physical therapy, some of the counseling and other lifestyle changes that would help people deal and cope with their chronic pain condition for the decades that they're going to have it. Instead, there's this belief that we can somehow medicalize it away, and that's problematic.